We are so happy today to have Mr. Ralph Weber, who is from the insurance industry and is going to be talking with folks about high deductible plans. And I would really appreciate him giving some more information about his background. Thank you so much for being with us today.
Sure. Well, a little bit about my background. I'm originally Canadian. I grew up in Asia and Europe, though, most of my life. I came back to Canada and then moved to the States in Houston currently. Moved to Houston about 6 years ago, left Canada about 15 years ago. And I've been a healthcare consultant for about 27 years. My biggest focus on healthcare and healthcare policy is trying to, the big insurance companies, Blue Cross, United, Cigna, Aetna, Humana, have what we know as preferred provider networks, and they have secretive, preferred pricing that nobody knows about until 7 weeks after the procedure. There's a huge variance in this pricing. I analyzed the state of Tennessee's healthcare. $2.7 billion worth of claims, and within a couple of, we looked at every single procedure. CT scan of the abdomen with contrast, the median charges were $635. The high was $19,800. Within a colonoscopy, the median charges were $1,212. The high was $17,341. And when we looked at colonoscopy, CMS does an extensive survey of every single hospital in the U.S. every single year. They ask not only financial questions, but they ask safety questions. How many times was a patient dropped off a gurney, mortality, morbidity, et cetera, et cetera. And all of the providers that charged above $10,000 for colonoscopy were rated 2 stars out of 5. Everybody that charged less than $5,000 was rated 5 stars out of 5. So there's an inverse correlation between cost and quality. There's no transparency in pricing at all. And there are a lot of people that say, all we need to do is add transparency, and if we do that, it's going to solve all of the problems. I agree that transparency is absolutely necessary. However, I know that just adding transparency won't fix the problem. As a matter of fact, it'll probably exacerbate the problem, and here's why. The average American earning $37,000 a year has a deductible and out-of-pocket costs exceeding $5,000. Somebody earning $37,000 to come up with $5,000, it might as well be $1 million. And they're thinking, I could never come up with that. Once they need a procedure that exceeds that, once they exceed their out-of-pocket maximum, if you add a transparency and you showed them 2 different providers, one of them who had charges of $30,000, one who had charges of $90,000, and you said, it's going to be the same $5,000 out of pocket no matter where you go, they would probably pick the $90,000 one because they think that that's a proxy for quality. Okay, so there needs to be more than just transparency and cost. Okay, there needs to be some actual financial motivation. So that has been sort of my focus in terms of healthcare, in terms of educating people and working with healthcare systems, not only state health plans but private employers. There is a place for high deductible health plans. They can be effective, but there's also a place for low deductible health plans. Even though routine physician office visits aren't really an insurable event, so many Americans, as a matter of fact, if you Google right now, if you Google how many Americans cannot afford $400 for an emergency medical procedure, what the results will show is 42% of Americans can't afford $400 without putting it on, a Visa card or borrowing the money. So these people put off needed procedures because they, can't afford it. So putting these kinds of people in a high deductible plan just means they're going to forego the procedures. What I've seen in health plans is every year the premiums go up and they go up and they go up and they keep increasing. And employers ask their brokers, what can I do? What can I do to decrease these rates? And the brokers say, well, increase the deductible. Let's go from a $3,500 to a $4,000 to a $5,000 to a $7,000 to $7,900. And it gets to the point where the healthy people that just need routine stuff, okay, there's three kinds of people. There are healthy people, and 47% of Americans have medical costs that average $150 per year per person, okay, $12.50 per month. That's 47%, so almost half of Americans. Another 15% have costs that average $625 per person. So these people, the 65% of people, they're going to drop their health plans because they're going to say, you know, paying $2,000 for myself and my family, and then having to pay another $7,000 when I need it, just doesn't do anything for me. So they're going to drop it. The unhealthy people are going to stay on. Okay, so the challenge is filling the needs of those two demographics. Roughly less than 5% of the population, have consume more than 50, actually closer, almost 80% of the healthcare dollars. And these are the ones that satisfy their deductible by February of every year. They are no longer consumers. They will go to that $90,000 provider. They don't care if the health plans charge $250,000, $250 million. They really don't care, because once they hit their maximum in February, they kind of turn their brains off. Transparency won't help them to control costs. So how do you, the challenge is, how do you create a health plan that serves both of those demographics, okay? And that's the challenge. Most physicians have no idea what the hospital's charging, because most of these charges are facility charges. And most physicians, even hospitalists, even anybody, you know, beneath the CFO in the hospital doesn't even know what kind of charges are made. So the challenge is, and what we have taken on is creating a health plan that satisfies both needs. Now, I've sort of gotten a little bit past my background, so maybe I should just back off and ask Betty what you would like, you know, from here. That was just, you know, I got beyond that, so I'm sorry.
No worries. Actually, so usually the interns would have gone to visit, for instance, Dr. Emmons by themselves, and they wouldn't even have me be here. So I'm trying to be relatively unobtrusive. I'm here to like help if there's issues like photobombing or something shows up.
Right.
But I'm gonna let them just carry on the conversation with you as though I wasn't here.
Okay, sure.
And if there were people to show up, because the syllabus is posted to other physicians from the National Health Program, they will be muted. They'll comment in chat, and questions can come out of there. But we don't want them to be disturbing your interaction with the interns.
Okay.
Thank
sure.
you.
So thank you, Ralph. This is extremely relevant to the things that we've kind of been discussing amongst ourselves about what are the benefits and cons of transparency, and how do we, you know, what's the best way to do it. So really, anything you can speak to more about that and like how you view it, that's extremely interesting to me, at least.
And also how you would suggest that, you know, you say there's huge variability in what hospitals are charging. So what would you suggest to you know, kind of stop that from happening?
Okay. So there are three parties in the financial transaction of healthcare in this country. There's the patient, the doctor and or hospital. Okay, I'm going to lump them into one, and then the payer. And let's just generically call it Blue Cross, you know, being the largest insurance company, but it could be Aetna, Cigna, you know, et cetera. So you've got the patient, the provider, and the payer. So when you go to buy a big screen TV, a car, a pound of beef, like whatever you consume in a day-to-day basis, buying a house, buying an airline ticket, anything at all where you're paying your own money, the person that has the most control over that transaction is you, the buyer. Okay, you, the buyer. Priceline is a prime example. In Priceline, you're buying an airline ticket for yourself most of the time. Sometimes you're going for company travel, and if you do, the company probably says, you know, you can fly business class, you can fly first class, you can fly like whatever. They will usually have policies around that. But most of the time, you're spending your own money. In most things that we buy, we're spending our own money. Now, Milton Friedman once said, there are two kinds of money. Ashwin, do you know what the two kinds of money are?
I guess I'm thinking like credit versus like money that you have in your hand. No.
Close. Your money and my money. Two kinds of money. Okay. Now there are four ways to spend money. You spending your money, me spending my money, me spending your money, and you spending my money. Okay. So those are, and I love how Milton Friedman just boiled it down really simply. Okay. When you're spending your own money, you're going to take care of it. You're going to be very careful. When you're spending my money, and I'm not picking on you personally, but you know, generically you, it's like, I don't care. So if I say, you know, Bree, hey, listen, I'm going to buy you dinner. You're thinking Ruth Chris Steakhouse, and I'm thinking Wendy's, right? So if I say, hey, here's $100, go buy yourself dinner, you're going to go to Wendy's and put $90 in your pocket and go for cocktails later on, right? So again, it shows, and again, I'm not picking on anybody individual. I'm just saying that this is, you know, sort of, you know, what on the large average, how people view money. And for example, a health savings account. If I say you've got a health plan with high deductible, but I'm going to put money in your health savings account, that becomes your money. Once it's your money, you might decide I'm going to get a generic drug versus a name brand. You might decide I'm going to get an X-ray versus an MRI, you know, et cetera. So you're going to control your own money a little bit more than if it's just there's a $10 copay and you go wherever you want. There's a $5,000 deductible and you go wherever you want. So there's only one person in America which has what's the population now? 328 million. There's only one person that can control healthcare costs, and that's not the president. That's you, the consumer. Okay, it's not you, the doctor. It's not you, the payer. It's you, the consumer. It's you, the patient. Okay, that's the only person when you're buying a TV. You're the only person. I mean, you're not going to call Best Buy and say, hey, send me a 65-inch TV and the invoice. You're going to look at Best Buy, you're going to look at Costco, you're going to look at Amazon, you know, et cetera, and you're going to compare, and then you're going to decide how much you're going to pay. You're going to compare the quality, et cetera. So the person that has the ultimate control of the healthcare spend is the patient. Now, in healthcare, it's a third-party payer system, okay? And again, that payer is the insurance company. Okay, you're the consumer of healthcare services, the doctor's the provider of healthcare services, and both have a moral hazard to try to game the system, although most people don't intentionally try to game the system, but all they know is my deductible is $5,000. And because of the convoluted opacity that we have in the system, they don't even know until they get their EOB 7 months after the service has been provided. So what we do, and HSAs are great in a high deductible health plan with a health savings account. That's a great way to control healthcare dollars until you get to that maximum out of pocket. However, once you're past that, boom. There's no more consumerism. And as I said earlier, that 3 to 5% of the population that consumes almost 80% of healthcare dollars, those are the ones where by February, they just say, hey, look, I've hit my maximum. That's it. Now, I talked to you about the two categories of people. There's one category in between, and those are the people that generally are healthy, generally have low expenses, but once in a while, you know, somebody will have a child. And that's a large expense. Once in a while, somebody will have a car accident. That's a large expense. So it's unforeseen. They're not chronic consumers of healthcare. They're occasionally large consumers. On those years that they have a large event, those are the ones that in October, November, and December, they go to the doctor and they say, okay, what can we get done? You know what? I was thinking my knee really hurts. I might as well have a knee replacement, et cetera, et cetera. Then they become over consumers because at that time they feel they're all in. They've satisfied their deductible. So, you know, that's the third category. So how do you, the challenge that I face is how do you control the people that, not control the people, that's the wrong term. How do you control the spending given the 2 or 3 diverse needs and desires of these different people, okay? You give them, number one, transparency, absolutely, but you can't stop there. You have to give them the financial control of the spending and the motivation, okay? Now, there's a new kind of health plan that is growing very, very rapidly in the US, and that's called reference-based pricing. Reference-based pricing, instead of having an insurance network, and within any insurance network, there really is 3,000% variance, sometimes in the very same city for the very same procedure. As we saw with the CT scan, and a CT scan really, I mean, it's really a commodity. I mean, yes, you could have a 256 slice scan, 512, et cetera, but you can commoditize a CT scan or an MRI, much more so than a surgery, certainly more than a neurosurgery or cardiac surgery. But still, an experienced surgeon, if you look at the main components of healthcare, let's just take a knee replacement to be simple. The main costs of a knee replacement are, number one, the surgeon's fee. Number two, time in the OR, because the hospital bills by 15-minute increments. Number three, anesthesia time, again, by 15-minute increments. Number three, nights in the hospital. So if you have an experienced orthopedic surgeon that does 500 knee replacements a year, they're going to be in and out in half an hour. Relatively little OR time, relatively little anesthesia time. And because you're only under for half an hour, you might not even have to stay overnight in the hospital. An inexperienced surgeon that takes maybe an hour and a half or 2 is going to require more OR time, more anesthesia time, and they're probably going to say, you know what, you were under anesthesia for 2.5 hours. We're going to have to keep you in for a night for observation, okay? So the cost is actually higher. So that's why we see the inverse correlation between cost.
Your sound became muted.
Yeah,
Ralph,
we just
can't hear you anymore. We still can't hear you. Just FYI. You're muted now.
try to. Yep. Nope. Still nothing.
Yeah, that's weird.
Okay, how about now? Can you hear me?
Got it. Yep.
Okay, good. Sorry about that. My phone dropped. I'm back on. So where did you lose me?
You were talking about the insurance plan, the referential.
Oh, reference-based pricing. Okay. So within a preferred provider network, you literally do have 3,000% variance within a procedure. So with reference-based pricing, the plan will pay a multiple of Medicare. The Medicare rate is supposed to represent the actual cost with zero profit of providing a service. That is supposed to be the pure cost based on the hospital surveys. So a reference-based pricing plan might pay the Medicare rate plus 50%. In other words, the cost plus 50% margin, okay? So a reference-based pricing plan, and usually they have differentials. It might pay higher within imaging, higher within, ER services, et cetera. So reference-based pricing says this is what the plan will pay, Medicare plus 50%. One of the things that my company does, medibid.com, is we have 120,000 providers in 14 countries that will bid when you make a request for, let's say, a knee replacement, any shoppable procedure. They will say, here are my quality ratings, here are my outcomes, here's my price, here's my location, and then they'll show you their profile. So if you have a plan, and you know, for example, a knee replacement, Medicare, the Medicare rate is roughly $14,000. Okay, now there are multiple different modifiers. A teaching hospital gets paid more, et cetera. But Medicare would pay roughly $14,000. So 1.5 times that is roughly 21,000. So if you as the patient is told, you know, your plan will pay whatever Medicare pays plus 50%, you know that's $21,000. You can go anywhere you want. And if the provider wants 22,000, you pay the difference. If they want 18,000, sometimes the employer will provide an incentive, such as sharing in the percentage of savings. So that makes the patient the consumer, because they have a vested, it's a carrot and stick approach. If you go above 21,000, you pay the difference. If you go below, the employer is going to share in the savings. That also steers you towards the cost-effective providers, which, you know, by anecdotal example and by the example of the colonoscopy with $2.7 billion of spending, it shows the difference in cost and quality. So you're often usually getting a higher quality provider for that, but it definitely puts you in the driver's seat as the patient. I know that was kind of a long answer to Ashwin and Liat's question, but I hope that answered to some degree what I was talking about.
Yeah, that was really great. So how do you go about trying to increase the value of care that's provided? Like, who specifically do you work with?
We work with anybody and everybody that's willing to work with us. We from the user side, from the patient side, we work with state health plans, private employers, et cetera. From the provider side, anybody and everybody. Everywhere from Texas Children's Hospital to private surgery centers to HCA to Tenet, Baylor, MD Anderson, you know, Vanderbilt. We don't draw the line as long as they meet minimum service and quality criteria. We don't dictate the pricing. We let them set their own pricing, and we let them sell their own pricing based on their quality and value that they provide.
So do you work with I'm just a little confused. Do you work with the insurance companies, or are all your patients paying out of pocket when they accept a doctor on the site?
Perfect question. Within the third-party payer model, you can go with a Blue Cross, Aetna, Humana, et cetera, or you can go with a private insurance administrator. When you go with a private administrator known as a TPA or third-party administrator, they can either give you a plan with a network. They can say you can have the Cigna network, the Aetna network, whatever. They can put that in, and then you have, you know, sort of just a regular network, or they can say reference-based pricing. Even the big companies like Blue Cross are able to do reference-based pricing instead of having their network. Within the network model, one of the problems, you know, as I mentioned earlier, is the big variance in pricing, sometimes exceeding 3,000% from a hospital right across the road. And I can't explain why that is. Every provider is able to negotiate their own prices, and most of the insurance companies have wide networks and they have narrow networks. Within the narrow networks, they generally take providers that charge less, but then there's less choice. Within the wider networks, they're generally a little bit more expensive, but then you have more to choose from. In the state of Tennessee, when I analyzed the $2.7 billion worth of claims, the out-of-network providers actually were being paid, 6% less than the in-network providers. And they had a narrow network. So 6% of $2.7 billion, those are substantial savings. That's a couple $100 million a year that could be saved just by going out of network all the time. And what that illustrates is that a network, every insurance company has a network. When you stay within the network, it's kind of based on price fixing. It's whatever they've negotiated behind closed doors that dictates the price that will be paid. If you go out of network, that's any provider in the state, that not only just in the state, but in adjoining states as well. So when you remove the requirement to stay in network, you have a lot more competition, and competition in every aspect of the economy, even in medical care. If you look at LASIK surgery, if you look at what's happened with LASIK surgery in the last 10 years, quality's improved, cost has come down. So when you have competition, that's what happens in every aspect of the economy, and it works in healthcare as well.
So I'm wondering, this marketplace sounds amazing for things like hip surgeries or LASIK or things like that, where a patient has time to plan and it's not life threatening, so they can do it whenever. But I mean,
Right.
how do you implement competition when you're talking about like an MI or something that you're not necessarily planning for?
Great question. An MI, emergency room visit, a lot of these things aren't shoppable. Now, emergency room comprises roughly 3.79% of claims on a large, let's say 4% on a large scale, so it's not a huge amount. Primary care office visits, they're probably 80% of claims, but only 10% of, maybe 20% of spending. So the emergency procedures, obviously are not shoppable, but we've shopped things as large as cranial vault reconstruction, thoracic kyphosis, a cabbage procedure. So we do shop major procedures, not just orthopedics. Most procedures are, but not all, most are shoppable. MI, trauma from a car accident obviously is not. But most of them are. So those ones that are shoppable, we do shop. Those that aren't, the plan pays whatever the plan pays. And sometimes we'll negotiate a safe harbor contract with the hospital where we say, okay, in the case of emergency, we'll pay double what Medicare pays, 2 times what the Medicare rate.
So you said you work with like a lot of these commercial insurance companies, and I mean, we're talking a lot about like kind of this consumer market, but where does that leave all those people who you're saying can't afford that $400 a month, or if they're on Medicare or Medicaid? Like, are they allowed to, do you work with those insurers as well, or how do they fall in?
Yeah, let me try to see if I can pull up a document and then share it. Just give me a second here. Because I think this will illustrate really well here what I'm talking about. Let me just open 1 second here. And then I'll share this on my screen. I talked about, especially post-COVID, there's a lot of Americans that have been underemployed, unemployed for a long time. They spent a lot of their savings, and those people are really hurting. So they just can't afford, these kinds of costs. Let me just see here. Here we go. Okay. Oh, host disabled participant screen sharing. Okay. So Betty, can you do something to allow me to share my screen?
It's actually Leet's account.
Yeah, I can do it.
Okay.
Okay.
I keep on mispronouncing your name, especially since it's written right there, and I keep on doing that. I'm sorry.
There we go. Okay. Okay, so can everybody see my screen?
Yep.
Okay. So at the bottom, you have preventive care. As per the Affordable Care Act, has to be paid at 100%, no copays, no deductibles, no anything. So a lot of people, a lot of brokers feel that all you need is a high deductible health plan after a $7,900 deductible. And this particular health plan, it pays a virtual consult subject to a $20 copay, generic drugs subject to a $10 copay, and really nothing else. Okay. Now, you can buy down the deductible with a medical expense reimbursement plan. You can buy it down to $6,000. You can buy it down to $4,000. You could buy it down to $2,000. So any individual employee in this marketplace can buy down their deductible based on affordability and need, okay? These portions in the middle here are self-insured. Now, another concept on the second tab of my worksheet is a plan with a zero deductible. Okay, again, preventive care is covered at 100%. You've got your telemedicine and your generic drugs. And then, a plan could be designed. And I've actually designed these plans that cover one emergency room visit, one night inpatient stay, and 2 outpatient procedures. And then you can have other things, doctor's visits, you can have, chiropractic, physical therapy. You can add anything to that you want. A lot of people argue, well, what happens if I have 2 nights inpatient stay? What if I've got COVID and I'm at ICU, et cetera? Well, if you're on this plan, you're going to stiff the hospital for $7,900. I'm sorry. That's what a lot of Americans that are earning $20 an hour or less are going to do. They're just not going to pay at all. If you're on this, at least the hospital will get something. They'll get paid for a night or 2 outpatient procedures. And this could be, it doesn't have to be 1 night. It could be, 2 nights, 3 nights, 5 nights. So we tailor that based on the affordability and the needs. But the reason that I have these 2 diagrams is that they are the exact opposites. Now, Bob wanted me to talk about high deductible health plans. So if we just take this out and we take this out and we say, here we go, there's your high deductible, and let's just say that there's absolutely nothing in between here, okay? You've got your preventive care, and then you've got absolutely no coverage until you hit $7,900. Plan like that will probably cost, I would say, depending on demographics of the group, between $300 and $500 for a single person, between $1,500 and $2,000 for a person with a full family. So the typical American worker that earns $37,000 a year that has a family of 4 that has to pay $1,500 for his health plan, and then it doesn't cover anything for the first $8,000, isn't going to be very satisfied with a plan like that. The plan with the zero deductible could cost roughly the same. There are limits on how many procedures it will cover, but for 80% of the people, if not more, that's going to be sufficient. So 80% of the people are covered by this plan, whereas this plan caters to 5% of the people. So what can you do about that? You can offer both plans and let the people pick which plan they want. If they say, hey, look, I really don't need health insurance unless I have a catastrophic event, and I've saved up, $7,900, or I've got a high credit limit or a home equity line, they'll choose this plan. The people that say, hey, look, I'm just an ordinary everyday person. I don't know if anything's going to happen, but I might have a baby. And if I have a baby, I might stay in a hospital at night. I might go in for an emergency C-section. I might have a knee replacement. So these are everyday things. Now, these are actually really low limits. Normally, my plans have 2 ER visits, 3 nights inpatient, and 3 outpatient procedures. Increases the cost to about $300 to $350. But these are the 2 basic opposing concepts on how to develop a healthcare plan that caters to, the mistake that most people try to make, that most people make, is trying to please all the people with a one-size-fits-all approach. And that generally, doesn't work.
So in this second plan, the zero deductible code, this
Right.
one, if you go over that, I mean, say you have somebody has a baby, but they're having an issue, and so they actually are on bed rest for the last month in the hospital. Like, does that mean that they're just on the hook for 100% of what's not those 2 or 3 nights that's covered?
Yes and no. Technically, they are on the hook for that. However, practically, they're never going to pay, and the hospital's never going to come after them because they know they can't pay. Okay, same, and it's the exact same with the high deductible. The hospital, even Cleveland Clinic has said that they're not going to ever sue a patient because they know that somebody earning $37,000 a year can't afford $8,000 out of pocket. They know that, okay? And a lot of the hospital pricing has taken this into account because they know that they can never satisfy it. They just say, okay, we're going to charge more to the insurance company because we know at least the insurance company will pay. But even then, a lot of the hospital CFOs that I know will say, okay, here's the general, the pricing game, okay? The hospital charges $100,000, let's say for a knee replacement. The insurance company says, we're going to take this arbitrary 55% discount because we want to look like we've really, beat you up, and really negotiated hard and gotten you a really good price. So we want them to think that we've gotten it from 100 down to 45. So of that 45,000, you, the hospital, have to collect $7,000 from the patient, okay? So that leaves $38,000 from the health plan. Once you start you, the hospital, try to start collecting from the health plan, it's going to go back and forth with somebody who's going to, decide whether was that patient actually eligible, was it medically necessary, could they have done a knee scope instead of a knee replacement, et cetera, et cetera. Most hospital CFOs will tell me that they are lucky if they collect 10 cents on the dollar for that deductible and out-of-pocket cost, and they're lucky if they collect 2/3 of the time from the insurance company. So in other words, of that $7,900 deductible, they're lucky if they collect $790 on that $38,000 remaining from the health plan. They're lucky if they collect $25,000 of that. So the average hospital will get about $25,000 for something they've billed $100,000 for. So most hospitals are billing such ridiculously high amounts in the hopes of getting 25% of that. And it's just, in my mind, it's an administrative game that's wasteful on resources, on administrative resources and billing. That's why I believe in competition. Let the hospitals dictate their terms, their prices, their quality, and say, here, we want your business, and we're going to compete for it, because that way the efficient ones, and not necessarily the big ones, but the efficient ones that are cost effective, that have high quality surgeons that are cost effective, that can do it in less times, are the ones that will be the providers of service.
So how would this affect more rural hospitals or smaller healthcare systems, you think?
Okay, perfect question, because I get asked that all the time. Most people assume that the rural hospitals are going to be the ones that are the most hurt. We have found often that the rural hospitals actually are more competitive. Medicare, when they set rates, they have a few criteria which will vary what a hospital gets paid for a certain procedure. One of them is what's called HOPD rates. And I forget what HOPD stands for, but HOPD rates are paid for an outpatient surgery that's performed either in a hospital or in an outpatient ambulatory surgery center that's owned by and connected to a hospital. So if you have, a St. Thomas Hospital and one brick connects an ASC to that hospital, they get paid 40% more than if that brick was not connecting those two hospitals. That's a 40% variance in what Medicare pays. Teaching hospitals get paid a lot more because they have, residents and interns that are there that they have to pay for. So sometimes there's, the attending has a couple of other, students with them. They get paid more. So there's a huge variance in even what Medicare pays. Often there's the urban hospitals get paid more than the rural hospitals. So the rural hospitals say, look, we are more efficient because we've adjusted our budget to this lower payment system so we can compete. So if a patient is told, look, by driving, maybe an hour and a half for your procedure, you can save money and get a reward because you've saved the employer money. Not only can you save, but the cost is sometimes more cost effective.
And I guess I come from the perspective that the more sort of like in health systems where every single procedure is covered, that you get better overall health outcomes. And you can also, depending upon how the incentive structures are, I'm thinking of course of Great Britain. I think it's a pretty good example, where you get better outcomes and ultimately the costs are lower. It's obviously a very different system. What is the kind of core motivation in this model? Is it about price control? It sounds like that's the real focus. What do you think? What do you say?
Okay, good question. I think the focus in our current system is about profits. Okay, in the system that I try to design, it's about making it cost effective. Having lived in Canada, having lived in Thailand, having lived in Nepal, having lived in Germany, I've seen many healthcare systems. Whenever you have a government subsidized health plan, such as England, okay, such as Germany, Canada, there are two kinds. One is single payer, and single payer means that there's only one tier. It's, the taxpayer funds all healthcare. There's no copays, there's no deductible, there's no coinsurance, and it's actually illegal for a doctor to charge privately for a covered service. Now, there are only 3 countries in the world that have single payer healthcare. That's Canada, Cuba, and North Korea. Okay. In Canada, it's illegal to pay for medical care. My former wife waited 2.5 years for bunion surgery, and they gave her a cane, they gave her a walker, they gave her Vicodin, but she was on a waiting list for 2.5 years. Eventually, that's why we moved to the US, so that she could get her surgery, because she couldn't get it in Canada. The countries that have 2 tiers, such as the NHS in Britain, Germany, Denmark, et cetera, there's at least a private option. So you can either get private insurance or at least pay a doctor. Those systems tend to be a little bit more competitive. The reason that they're more cost effective, as I said, our system in the US has much better technology, often much better physicians, much better capabilities. However, sometimes there's an incentive to go for the higher cost of care, even though it might not be more effective. And for example, that illustration I made earlier about the inexperienced surgeon having higher charges, if you add cost transparency alone, it's going to actually steer people towards that. So they will end up paying more and getting lower quality of care.
So what would you say in response to the fact that studies have shown that a single payer system would reduce costs of healthcare in America substantially?
It might. However, it'll also reduce choice. Okay, it'll also increase waiting times. I've lived in a single payer system. Like I said, my former wife waited 2.5 years for a simple bunionectomy. In Canada has 10 provinces. Each one has their own healthcare system. The Canada Health Act, when it was written, was 13 pages long. It's now 16 pages long, compared to the ACA, which is 2,700 pages long, plus 20,000 pages of regulation. Okay, and this is, I'm sort of making light of this, but I almost think that most hospitals in America have more attorneys than they do physicians. Okay, and they have more administrators than they have physicians. Now, there's a show on Amazon Prime, and it's a British comedy. It's called Hello Minister. There's an episode on Hello Minister that I would suggest you watch. You're gonna bust a gut. It's really funny. It's about how the NHS builds this hospital, and then they hire 500 administrators, and their budget runs out. They can't hire doctors, so they don't have patients. They have 500 administrators and no doctors and no patients. It's a really funny episode, but sometimes that can actually happen, where you have so many people administering health plans and nobody actually to provide the care. So in a government payer system, you're not going to have that huge 3,100% variance, okay? But you're going to have waiting lists, okay? You're going to have rationing of care. You're going to have fewer choices. The US has 8 times on a per capita basis, 8 times as many high-tech imaging, MR, CTs, et cetera, than Canada does. So like I could literally right now in Houston, I could pick up the phone, I can get an MRI, well, it's 3:20 where I am. I might not be able to get it today, but I can get it at 9 a.m. for $275. I can get an MRI. In Canada, I'd be waiting 13 months for an MRI. So, you know, that ability would go away. Okay. Would we spend less? Quite possibly, but we'd have to wait longer. Now, the second question, and one of you might be formulating this right now because I'm asked this all the time. Why aren't those people freaking out and complaining? Okay, why aren't they saying this is crazy? Okay, number one, because the people that need critical care at any point in time is a relatively low percentage of the population. Okay, it's the minority, and they're not a vocal minority. 80% of the people that have just routine stuff, if you break an arm, Canada's great. You go in, they're going to fix it. It's not going to cost you anything. Okay, but if you need a cabbage, thoracic kyphosis, you know, something really high tech, even MR or CT, you're going to be waiting and waiting and waiting. In British Columbia, you can't actually get a knee replacement before you're 60 years old, because they say a knee replacement lasts about 10 years. We're not going to pay for 2. So if you're 58 and you need one, you have to wait 2 years. If you're 53, you have to wait 7 years or leave the country, because within Canada, you can't pay privately for that care.
So what, I know you said you lived in Germany as well, correct?
Correct.
I know Germany has an all-payer model in which
Right.
there is predominantly the government pays for, I think, 88% of all healthcare
Correct.
costs. And then, so what are your thoughts on a mixed model like that, but is a lot more regulated than we have today? And then also you've seen that Germany has way better health outcomes than we do and spends almost half as much.
Yeah, in Germany, it's income based. If you earn more than, I forget the number, I think it's like 60,000 euros, you have to buy private insurance. In Germany, when you buy private insurance, when you go to the hospital, you're generally seen by the chief of orthopedics, the chief of pediatrics, you know, like you're seen by the chief of that department, not the attending, not the intern. Okay, so because of the private insurance, it pays for a different level. So that's sort of a different than NHS, where you can buy private insurance or buy, you know, get the public based on your outcomes. Denmark has an interesting model, and we're actually working with Denmark. I was speaking to somebody from Denmark today. We have a meeting on Wednesday. In Denmark, if your waiting time they have predominantly, you know, government sponsored. If your waiting time is expected to exceed a certain time frame, which is 30 days, except for cardio and neuro. If it's expected to exceed 30 days, you can go anywhere you want. You can go to Stockholm, London, Berlin, anywhere you want, and the government just writes the check. A couple of years ago, after this bill passed, a member of parliament said, hey, wait a second. Whenever the government pays for something, we have to go send out an RFP and we have to get 3 bids on that. How come we don't have to do that when Joe Blow has to go for a knee replacement to Berlin? Oh, good point. So they've actually been talking to us about getting bids when somebody leaves the system. So, you know, because just writing that check means that the provider will charge whatever they want. So I don't think anybody has the perfect solution. You can control cost, you can control outcomes, you know, there's a lot of things you can control. You know, including spending, but trying to control them all is very difficult. So having a multi-tiered model certainly is more effective. Now, if you compare total out-of-pocket costs between Canada and the US, of the people in the US, actually, the US has lower out-of-pocket costs. If you pretend that health premiums are not part of out-of-pocket costs, if you're talking just about deductibles, copays, coinsurance, et cetera. For example, in Canada, prescription drugs are not at all covered by the provincial health plans. Okay, that's not covered at all. Okay, and a lot of procedures, they're covered if you can wait long enough to get them. Okay, so Canada actually has higher out-of-pocket costs. I think roughly, and I talk about this in the last book that I wrote on healthcare. I talk about the difference in the out-of-pocket costs in Canada versus the US. Did that answer your question, Leah? I'm not sure. Yeah. Okay.
So I guess how could you see your current plan covering, do you see, or even do you see your current plan being able to cover every American, or is that not necessarily the point of the plan?
It is and it isn't. I have two different sort of companies. I have MediBid, which just allows, just like, excuse me, just like Travelocity or Priceline allow people to shop, and it allows airlines to post their prices, and it's based on occupancy. If I wanted to book a flight tomorrow to Nashville, and there was a flight with 20% of the seats sold, it's going to be less than if 80% of the seats are filled. Okay, so it's based on occupancy. Our healthcare pricing is not based on occupancy, and it's not based on competition. Competition makes all markets more efficient. For example, if we didn't buy Samsungs and LGs that were made in Korea, we'd all have RCA TVs that are 19-inch CRT black and white tubes, and they'd cost $850. Because of competition, we have gained in efficiency. So could we create a model that would allow all Americans access to affordable care? Absolutely. Would it be more cost effective? No question. One small company, and we just did their renewal last week. They had, let me see, 214 employees, and of the 214, 80 were covered by the health plan. They were paying $788,000 a year with one of the big insurance companies prior to us taking them over a year ago. We saved them $290,000 out of $780. We reduced their deductible from $3,500 to $0. We just did their renewal. They got a 3.67% decrease in rates. Okay, so we saved them over a third the first year, and then gave them almost a 4% decrease the second year. So what it shows is that competition is working. It's increasing choice, it's decreasing out-of-pocket costs for employees, it's giving them more access to care. They can go to any provider, they don't have to stick within a narrow network, and it's decreasing costs. So can it be done? Yes, we're doing it every day.
Well, thank you very much, Ralph. I do need to go. Does anybody else have any questions? I want to hear them if people are going to ask.
No, I have another meeting I have to run to, unfortunately, as well. But thank you very much, Ralph. This was pretty enlightening on a different model than what I had really considered was an option.
Sure. Happy to be here.
Thank you.
Yeah, thank you for being willing to do this talk. I really very much appreciate it.
Not a problem. Good to meet you.
Thank you so much. Appreciate your time.
Sure. See you.
Thank you for
Good luck.
recording that.
Yeah, thanks. Bye.
Thank you. Bye-bye.